Effect of rheumatic diseases on the cardiovascular system. Abstract. Rheumatic diseases including rheumatoid arthritis, systemic lupus erythematosus, SLE, systemic sclerosis, and vasculitis are systemic autoimmune disorders with substantial effects beyond the joints and connective tissue. One of the most clinically significant and potentially life-threatening complications of these diseases is cardiovascular, CV, involvement. This article reviews the various mechanisms by which rheumatic diseases affect the cardiovascular system, clinical manifestations, diagnostic considerations, and current strategies for prevention and management. Introduction. Cardiovascular disease, CVD, is a major contributor to morbidity and mortality in patients with systemic rheumatic diseases. Traditional CV risk factors alone cannot fully explain the elevated risk in these patients. Chronic systemic inflammation, autoantibody-mediated damage, and accelerated atherosclerosis play central roles. Understanding these associations is crucial for early diagnosis and targeted management. Pathophysiological mechanisms. 1. Chronic inflammation and endothelial dysfunction. Pro-inflammatory cytokines such as TNF-α, IL-1, and IL-6 promote endothelial activation, reduce nitric oxidability, and enhance oxidative stress, which accelerates atherogenesis. Amtanshar 2. Autoantibodies and immune complex deposition. Autoantibodies, e.g., anti-dsDNA and SLE, anti-CCP and RA, can directly or indirectly damage vascular and myocardial tissues via immune complex deposition and complement activation. 3. Accelerated atherosclerosis. Patients with rheumatic diseases often show features of early and rapidly progressive atherosclerosis. Inflammation alters lipid profiles and enhances plaque vulnerability. 4. Microvascular dysfunction and vasculopathy. In diseases like systemic sclerosis, microvascular abnormalities are prominent, leading to Raynaud's phenomenon, pulmonary arterial hypertension, and myocardial fibrosis. Cardiovascular manifestations by disease. 1. Rheumatoid arthritis, RA. Increased risk of ischemic heart disease and sudden cardiac death. Pericarditis and myocarditis may occur, often subclinical. Higher rates of heart failure with preserved ejection fraction. Carotid intima media thickness is increased, reflecting subclinical atherosclerosis. 2. Systemic lupus erythematosus, SLE, high prevalence of premature coronary artery disease, CAD, especially in young women. Liebman-Sachs endocarditis, non-bacterial thrombotic endocarditis. Pericarditis is the most common cardiac manifestation. Lupus myocarditis and conduction abnormalities may also occur. 3. Systemic sclerosis, myocardial fibrosis and diastolic dysfunction. Pulmonary arterial hypertension is a major cause of mortality. Arrhythmias and conduction defects due to fibrosis of the conduction system. 4. Vasculitis. Large vessel vasculitis, e.g. Takayasu arteritis, GCA, can cause aortic aneurysm, dissection, and occlusive disease. Medium and small vessel vasculitis, e.g. polyarteritis nodosa, ANC-associated vasculitis, may involve coronary arteries or lead to myocarditis. Diagnostic considerations. Echocardiography, essential for detecting pericardial effusion, valvular lesions, and pulmonary hypertension. Cardiac MRI, valuable for assessing myocardial inflammation and fibrosis. Biomarkers. Elevated CRP and ESR indicate systemic inflammation. Troponin and BNP may suggest myocardial involvement. Vascular imaging. Carotid ultrasound and CT angiography help assess subclinical atherosclerosis and vasculitis. Management and prevention. 1. Control of systemic inflammation. Disease-modifying antirheumatic drugs, DMARDs, biologics, e.g. TNF inhibitors, and corticosteroids. Methotrexate and hydroxychloroquine have been associated with reduced CV risk in RA and SLE, respectively. 2. Management of traditional CV risk factors. Hypertension, diabetes, and dyslipidemia should be aggressively managed. Smoking cessation and lifestyle modifications are essential. 3. Antiplatelet and statin therapy. Statins have anti-inflammatory as well as lipid-lowering properties. Low-dose aspirin may be indicated, particularly in SLE with antiphospholipid antibodies. 4. Monitoring and screening. Regular CV risk assessment should be part of routine care in patients with rheumatic diseases. Consider stress testing or coronary calcium scoring in selected high-risk patients. Conclusion. Rheumatic diseases significantly increase the risk of cardiovascular complications through complex interactions between systemic inflammation, immune dysregulation, and traditional risk factors. Early recognition, vigilant monitoring, and integrated management strategies targeting both inflammation and cardiovascular health are key to reducing morbidity and improving survival in these patients.